Today, Dr. Sinead Delaney-Moretleway, Associate Professor and Director at WITS Reproductive Health and Research Institute in Johannesburg, will present findings from the Empower trial and share lessons learned from the experience of delivering combination HIV prevention to adolescent girls and young women. The presentation will be followed by questions and a discussion. Thank you, and over to you, Sinead.
Thanks very much, Meghna, and good afternoon or good morning to those of you on the line. Thanks very much to the STRIVE Consortium for giving the Empower team the opportunity really to share our results with you. Just to note that this project was obviously a collaborative project and the result of a team effort of a number of STRIVE partners, including WITS RHI, the London School of Hygiene and Tropical Medicine, the Mwanza Intervention Trials Unit, and AGYW in the US. And for those of you who are on, I think, last month's Learning Lab, you may already have heard a little bit about Empower, and I'm really going to focus on the work that we did to evaluate the potential of empowerment clubs to enhance PrEP continuation. So just to give you some background to the Empower study, when we designed Empower, there was a great deal and remains a great deal of concern about the high rates of HIV infection amongst adolescent girls and young women, particularly in the African region. And in addition, what we were aware of is the high rates of violence against women and girls globally, but in particular in the African region. The data from the WHO study suggested that about a third of women had experienced violence from a partner during their lifetime. What we had also seen from our work in Johannesburg and from the VAC surveys was that even younger women, sort of between the ages of 15 to 24, also about a third of them had already experienced some form of violence from a partner. And so clearly, both HIV and violence against women were significant threats to women's health, and we wanted to think about ways to potentially respond to both of those threats. What was also compelling at the time that we developed the project was this increasing evidence from longitudinal studies that violence actually increased the risk for HIV acquisition, and that it might account for about 20% of new HIV infections in women. And also, sort of during the life of STRIVE, we had conducted some work that suggested that violence and harmful gender norms actually undermine the HIV treatment cascade. And we have presented some of this work in previous Learning Labs, but just to refresh your memory, we conducted a systematic, or rather a review of systematic reviews to really look for evidence that violence and harmful gender norms undermined either HIV testing or antiretroviral treatment initiation or viral load suppression. And what we found from those reviews, although the evidence was mixed, was that overall violence and harmful norms appeared to undermine women's decision-making around HIV testing. And in some instances, violence and fear of violence prevented women from accessing testing, although in some studies it may also be a motivator for testing. When we looked at the evidence around the impacts of violence on ART initiation, what we found was more consistent evidence that in the majority of studies, violence actually led to reduced uptake of antiretroviral therapy, and so reduced current use. And this in turn translated into women being less likely to adhere to antiretroviral therapy, and that ultimately led to poorer clinical outcomes. So clearly there was evidence in the literature that violence and harmful gender norms had an impact on the HIV treatment cascade, but we were obviously interested in prevention, and so we looked at what data there was to indicate whether or not these same effects could be observed in the prevention cascade. And while the evidence is much more limited, there is data that is emerging from a number of oral PrEP trials, and now sort of more recently we're starting to see this in oral PrEP demonstration studies, which suggest that the effects that we see of violent and harmful norms on ART use are also being translated into PrEP uptake and continuation. So it's important to bear in mind that the trials were conducted in the context of high levels of violence, and what's reassuring to some extent is that we don't see PrEP being a source of conflict in relationships per se, but rather maybe reflect that episodes of violence are reflective of the general background violence. Another sort of noteworthy point coming from the literature is that fear of rape or past violence might actually motivate PrEP uptake, which may be important in PrEP programming. And sort of overwhelmingly, the messages that we're getting from these trials is that male partners have a critical role to play in the decisions about using PrEP, and that fear of violence may often lead to sort of non-use, intermittent use, or sort of attempts to conceal product, and so poor use amongst women. And also kind of what we are seeing from some of these trials now is that there does seem to be a strong association between reports of violence and suboptimal adherence. What's reassuring perhaps is that these effects appear to be short-lived, and sort of violent, reductions in adherence appear to be related to reports of violence but don't persist. But all forms of violence are important, not just physical violence. By contrast, many young women in particular are articulating PrEP as an empowering technology. So it was against this backdrop that we really wanted to see whether it was possible to address some of the potential that violence or fear of violence might have on PrEP continuation and use. And so the sort of what informed our thinking very much was data which has really been consolidated in this review, which was presented in the Lancet, which was a synthesis of the evidence for what works to prevent violence, and sort of both from high-income countries and low and middle-income countries. And what was most important for us was that we were getting data from low and middle-income countries. A number of trials had been conducted which suggested that interventions that involved community mobilization and where there were elements of empowerment training for women and girls that ideally used a group training approach with or without cash transfers did have the potential actually to reduce violence and conflict within programmatic timeframes. And some examples of these programs that you may have heard of were trials like the SASA trial and the IMAGE trial, and even the SHARE trial, which had all shown sort of promise for intervening to prevent violence against women. So it was against that backdrop that we framed this research question, and what we wanted to know was it feasible, and was it acceptable, and also was it safe actually to integrate responses to gender-based violence and harmful norms into an HIV prevention program that was offering PrEP for adolescent girls aged 16 to 24 years. And my colleague Manuela Colombini will have presented our findings about incorporating screening for violence within HIV counseling and testing. So what I want to do in this presentation is really focus on the question that we had about whether adherence clubs that included a 4-session empowerment curriculum could enhance PrEP uptake and continuation in these two contexts, in Johannesburg, South Africa, where we had an existing adolescent and youth-friendly service, and in Tanzania, a very different setting, where we were offering this program to young women working in bars and hotels in Mwanza district. So just to review the study design and population with you, we enrolled young women aged 16 to 24 years they were offered HIV counseling and testing, and to enroll in the study and to receive PrEP, they had to be HIV negative, sexually active, non-pregnant, with no contraindications to oral PrEP. And importantly, as part of the violence screening, they were excluded if they were at immediate risk for harm. And this was because in that instance, it was very important for us to link those young people to places of safety, because either they were at risk from harm from someone else or from themselves. Then young women who were eligible were then randomized, irrespective of PrEP uptake at baseline, into one of two groups, either a group that was offered a standard package, which was essentially counseling at clinic visits and SMS reminders in between visits, or that same standard package with the addition of empowerment clubs, which were offered monthly. And then as part of the follow-up for all young women and sort of aligned with existing PrEP programs, participants were asked to attend visits at month 1, month 3, and then quarterly thereafter for up to 15 months. There was longer follow-up in South Africa than there was in Tanzania. And at each of these visits, they received HIV counseling and testing, which included the violence screening, safety assessments essentially linked to whether it was safe to continue using PrEP, and then they received their PrEP. And all of this was offered within the context of youth-friendly services and as part of a comprehensive sexual and reproductive health package, which included offer of contraception as well as treatment for sexually transmitted infections. The primary outcome of the study was PrEP continuation at 6 months, and that was decided as the outcome in part because that was where we had data for all participants. But we have also looked at continuation at later months. And in addition to the data collected at each of the visits, we conducted a survey both at entry into the study and at endline. And in a select number of participants, we also conducted up to 3 qualitative interviews at both sites. So because this was a program really aimed at evaluating PrEP delivery for adolescent girls and young women, there was a fair amount of work to be done to provide PrEP support for participants. And as part of the package, when young women were initially counseled for HIV and found to be negative, we included a module around PrEP decision counseling. And all subsequent visits used a participant-centered counseling approach, which was based on a motivational interviewing approach adapted from the CAPRISA and the FACTS trials. All participants also got one-way SMS motivational messages and visit reminders, essentially inviting them back to the clinic for their follow-up visits, but also including messages really about planning for travel and other such reminders, which had been successful in previous PrEP studies. An important aspect of this study was the inclusion of community dialogues, and this is because we recognized from the violence literature that community mobilization is an important aspect of violence prevention, and had learned about the importance of these dialogues from the SASA trial. And so in each of the sites had at least 3 dialogues which were really involved a range of community stakeholders and were aimed at catalyzing conversations around healthy relationships and really sort of HIV prevention and violence prevention for young women. And this was also because we had learned from previous PrEP studies that it's quite difficult for young women to adopt preventive behaviors in the absence of some kind of community support. Another important thing to kind of reflect on from these studies is that at the time that PrEP was being offered within these studies, these were really vanguard studies where PrEP wasn't widely available within country, and these were very much sort of demonstration projects. And so many people hadn't heard about PrEP within the community, and it was important that we generate information and materials around around PrEP to facilitate demand. And that took the form of, we had a short film, we produced a number of these posters, which you can see were very much geared for the adolescent market and very sex positive, but also became aware of the need to provide information to other stakeholders, and really relied on materials that had been produced in country to provide information to other kind of interested gatekeepers like adult caregivers or parents, for want of a better description. So now just to tell you a little bit about the empowerment clubs. We decided on a 4-session curriculum, and this again was informed by a review of a number of the interventions that we knew had involved empowerment activities. And so kind of that range from interventions that had up to 12 sessions to evidence from much shorter interventions with as few as 3 sessions. And so we thought that 4 was an optimal number. It sort of didn't skimp on the content, but it also kind of would allow it to be scalable if we showed impact. And the curriculum really focused on the topics outlined there, so gender roles and social norms, power and control, sexual and reproductive health, and empowerment. And a lot of, and the material was really developed by our partners at AGYW based on a review of previous similar interventions, but adapted then for a younger audience. The clubs themselves were informed very much by the experience of the antiretroviral clubs, which were initially, I think, pioneered by Médecins Sans Frontières and have sort of had huge acceptability within the region. But also kind of, I think, paid attention to the lessons from the violence field, and so focused very much on being group-based and being participatory. They were led by a trained peer who was very much of an age of the participants, and you can see in the photograph the facilitator there talking to some young participants. We prioritized a non-clinic venue to kind of demedicalize the intervention as much as possible. We hosted them monthly. We aimed to try and make them 2 hours in duration. And we planned to have about 20 members per club. And so we had a number of clubs running at the same time. So just to reflect on the analysis, in the end, we've opted for an analysis which is we have articulated as PrEP continuation, and this is an outcome that can be quantified from pharmacy refills, and kind of we think is important for understanding both whether or not people are continuing PrEP, and also provide some insight into sort of whether they're taking pills and potentially are receiving protection during periods of exposure. The analysis itself was an intent to treat analysis, the primary analysis, but we also conducted per protocol and specified subgroup analyses. And then we looked at differences in PrEP continuation at month 6 using survival analysis, and looked at difference in those survival curves using a log rank test. We also wanted to explore whether there was differential efficacy in population subgroups. And we also did some analyses, which I'll share with you, that really looked at the associations between baseline characteristics and PrEP continuation, as well as club attendance. And what I'll do now is talk you through the results of those analyses. So in total, you can see from the figure that we screened 619 women across the 2 sites and randomized 431. And there were about just under 200 that were ineligible. The majority that were ineligible were actually people who didn't come back within the screening window or didn't come back for enrollment. And so we think that that is a population that essentially voted with its feet and decided that maybe PrEP wasn't for them. Nevertheless, you'll see a little bit later that uptake still within this cohort was very high. So the women were then randomized to either the standard of care package or the standard of care plus clubs. And importantly, sort of at end line, or rather at the month 6 outcome measurement point, we censored about 45 participants in each group. And these are people who were censored at the time of product discontinuation for a medical reason, which, for example, might have been HIV seroconversion, or in our protocol, we also censored women when they became pregnant, because at the time there wasn't sufficient data about safety of PrEP and pregnancy yet, at least, and there were reasons kind of not to offer PrEP then. And the other reason for censoring was essentially relocation, because participants who left the study area wouldn't have been able to receive refills. So here are the baseline characteristics. We've combined both South Africa and Tanzania just to kind of highlight that the majority of participants were in fact from South Africa. About a quarter of them were under the age of 20 years. And we know that age is associated with adherence, so this is important for us in terms of thinking about younger populations. The majority of them were unmarried, and about a third of them had ever experienced violence. And this is obviously very striking given how young they are. The next few variables really highlight for us that this was a population at substantial risk for HIV infection and met the criteria for using PrEP. About a third had more than one partner in the past 6 months. Consistent condom use was very low in this population. And while a lot of them were using contraception, so had adopted other health preventive behaviors, it's important to note that only about 15% of this group were actually using combined oral contraception, which is, would be a daily pill-taking habit. About 2/3 of them were nulliparous, so didn't have any children. And again, another sort of striking feature of these PrEP demonstration projects in young women is the high rate of curable STIs that we're seeing. About 1 in 3 young women had either chlamydia or gonorrhea. It was slightly different in Tanzania, where many more people had trichomonas, but still indicating an unmet need for STI treatment in this population. The voice risk score is really a score that's been designed based on previous PrEP trials and is has been shown to be predictive of HIV infection. So a voice risk score above 5 is predictive of an HIV incidence above, if I recall, 5%. And so again, reflecting that this is a population at substantial risk for HIV infection and would be eligible for PrEP within a PrEP program. And finally, sort of between 8 and 9 out of 10 of young women in the study articulated that they believed that PrEP would prevent HIV infection. So moving on to the first of the key results, the first striking thing about this slide is that PrEP uptake in this population is incredibly high. About 97% of young women who were offered PrEP accepted it at their enrollment visit, and this really exceeded our expectations. I think when we planned, we thought about 6 out of 10 would accept PrEP. So there really is huge interest in HIV prevention methods for young women. And maybe those that didn't return for screening sort of had self-selected them out. But this is a population at risk for HIV infection, but also that recognizes their risk and really has high demand for new prevention products. And I think the second thing that's striking about this graph is that if you look out to 6 months, about 60% of people are still using PrEP at 6 months. And there's a lot more work really to be done to understand sort of what is a reasonable period of PrEP persistence. What was important for us to understand was that participants were less likely to continue PrEP if they were married or living with their partner, if they were dependent on their partner for a source of income, and if they had 2 or more children with that person, or they didn't believe that PrEP would prevent HIV infection. And I think this starts to sort of illustrate the real importance of partners in influencing PrEP use, but also some of the challenges of introducing PrEP into a relationship where you have an intimate relationship with someone and yet kind of you're taking a pill a day essentially to protect yourself from an infection that person might give you. And so, you can see that it may be difficult to continue PrEP under those circumstances. And really, we need to learn more about sort of young women's lives and their relationships to understand sort of whether we're able with PrEP to cover all of those periods of potential exposure. So moving on to the next slide, and in fact the key result around the empowerment clubs is this one, and what you can see is PrEP continuation by arm with no difference between the Empower clubs and those who receive the standard of care. And this result was consistent whether we looked at it in terms of an intent to treat analysis, a per protocol analysis, when we used retention and care as an outcome, or when we stratified by pre-specified subgroups. So we were interested in whether there were differences between those who were older or younger than 20 years of age, whether those that had a higher risk score might perhaps have differences in outcome, and also those that may have experienced violence in their lifetime, whether there were differences. And we didn't see any difference in an effect. So we believe that this is a robust result. So why did we see this, given some of the evidence to suggest that violence or fear of violence really influences the PrEP cascade? And I think that the first important lesson for us is in this graph, where we looked at club implementation. And while you can see that a number of people went out to have many more than the sort of recommended 4 sessions, about half of the cohort in both sites never attended 1 session. And the reasons for non-attendance were really that these young women were very busy, they forgot about their club day, they had practical barriers to accessing the venues, which is often more of an issue for younger people than for older people. And what's important is when we looked at whether there were differences between those that attended club sessions and those that didn't, we really couldn't find any difference in the baseline characteristics that we had measured, suggesting that there are some unmeasured factors which may distinguish whether or not people attend clubs that are worthy of further investigation. We also kind of looked at the qualitative data that emerged from people who'd been exposed to the clubs to understand whether they were acceptable to those that had attended. And, I think one of the things that was most difficult for the study team was that we had been hearing such positive feedback from the club participants about the clubs through the qualitative data and through sort of interaction with participants, that it was really a surprise, or not a surprise, but really difficult to understand why people didn't attend. But those that participated in the clubs definitely experienced benefits. They talked about learning new skills and knowledge. They felt more empowered in their relationships. They were better able to recognize harmful relationships and to extract themselves from that. They talked about how they developed greater tolerance of other people, and they found catharsis and self-expression in these clubs. And this quote kind of reinforces that experience that young women articulated. So it was, we had mixed feelings about this result, but in summary, we were very happy as a group that PrEP uptake in this population was high. We recognize that it's diminished over time, but subsequently in sort of looking at how other adolescent demonstration projects have done, I think continuation at this level and even out to 12 months is reasonable, and it's useful to reflect on what we think about also oral contraceptive continuation rates in this age group. But very disappointing was could see by empowerment club participation. We observed that the empowerment club participation was low, and this was despite the enthusiasm of those that did participate in clubs. And we hypothesized a number of reasons for this. The first is that in both of these contexts, these young women were incredibly busy, had competing demands on their time, and that's the nature of young people's lives. We also reflected that in some settings like urban Johannesburg, where there isn't sort of one identifiable community, it may be very challenging to try to sort of build social cohesive groups within that environment. And particularly if you're trying to build club cohesion, essentially around an identity that is about being healthy and being sexually active. And that's in contrast really to the ART support groups, which have really helped young people who've perhaps been living with the stigmatized disease to identify other similar people to them and develop a community. And so these are some of our thoughts about why we may not have seen the benefit of clubs, at least for PrEP continuation, that we anticipated. And I think either way, this data is really useful data and really highlights the need for us to develop ongoing strategies to support PrEP continuation in young women and really to continue to look for ways to address the high levels of violence and harmful gender norms that they experience within their communities. And then just, I think, to close out and really acknowledge the tremendous contribution of the participants, the community advisory boards, particularly the youth CADs, who were incredibly active in helping to design and shape the services that we eventually offered, as well as the communities and the study teams who worked both in South Africa and Tanzania, as well as the partner institutions who provided violence referral services for those young women who had reported exposure to violence. And finally, to acknowledge the contribution of the various donors and partners who contributed towards this study. So thanks very much, and over to you, Meghna.
Great. Thank you very much, Sinead, for this excellent presentation. Very interesting findings. And we already have a few questions that have been typed into the chat box. To start off, there was a question on a methodological question, Sinead, which was on matching and whether it was done for two groups and how comparable are the groups, and it was through randomization.
So thanks for that question. And just to say that we randomized participants, so not necessarily through matching. It was individual randomization. We did stratify our randomization lists by site to make sure that there was balance in both sites. And if you recall the baseline characteristics slide, we didn't see much difference at all between the two groups, suggesting to us that the randomization had been successful.
Great. There was another question about definition and whether you can talk more about your definition of PrEP adherence and whether there was biological samples that were also considered and whether the study considered taking biological samples.
Sure. So there's clearly a field of literature about sort of the various definitions that are used sort of within PrEP programs to articulate really the steps that it takes to sort of initiate and then continue PrEP. And from our perspective, we were interested in a programmatic definition that really captured these ideas of people who initiated PrEP, that they continued taking PrEP for periods while they were at risk for HIV infection. The pharmacy refills allowed us to assess that by essentially assuming that all people were at risk for HIV infection, and that we then calculated based on their visits returned and kind of the pills that they had returned, whether they had taken sufficient product during the intervals between visits. And if they were late for visits, we obviously had a sort of buffer. So kind of at any point in time, did people have sufficient PrEP on hand? And those were sort of counted as continuous, whereas those people who missed visits, didn't come back for refills, were counted as discontinuing. And so it may be somewhat of an underestimate, because what we're learning from PrEP programs is that sometimes people cycle on and off. So they may stop PrEP for a period of time, and then they may restart, but we didn't sort of count those people in addition. We just sort of looked at people who had sufficient PrEP on hand during sort of visit intervals, and then kind of use that to kind of make assumptions about whether or not they were protected from HIV exposure. To the question of did we collect biological samples, we did, but there are kind of resources, kind of cost implications attached to testing, and there are limitations of testing methodologies insofar as plasma testing really gives you a kind of a view on the last 24, slightly more hours, and kind of there is a risk of white coat dosing. And dried blood spots give you a much sort of longer view, sort of around 3 months of sort of consistent PrEP use. They don't tell you about sort of missed visits, but the cost of those tests are much higher. So in the first instance, we opted for a programmatic outcome.
Great, thank you, Sinead. There's a question on attendance, and the question is a big proportion did not attend. And so how credible can we take these results, and was it linked to the intervention, and was there a difference in both groups?
So I think, and again, this is an important question, and I think it gets to the heart of sort of the conclusions we've finally drawn about this. So I showed you the intent to treat analysis, the Kaplan-Meier graph, but I also talked about how we looked at this also in the per protocol analysis, so looking at just women who attended clubs. And then we also looked at sort of within particular subgroups, did we perhaps see an effect? So for example, we could have hypothesized that women who had experienced violence at baseline might derive more benefit from the clubs and may be more likely to continue PrEP as a result. And whichever way we cut it, we didn't see an effect. So I think if we had seen perhaps only sort of the intent to treat analysis, no effect, but then in sort of some of these other analyses, an effect, I would have been sort of less confident. But I think, kind of it's a fairly complex pathway to move from empowerment clubs and adherence clubs all the way to kind of individual decisions to continue PrEP. And so I think this is a reasonable result. And I don't think we're saying that clubs don't have potentially other health benefits, and those are some of the ongoing analyses we're doing to explore whether there are additional, for example, mental health benefits or other benefits. And the other thing we're also doing is really to see whether maybe the empowerment clubs didn't impact PrEP continuation, but maybe they impacted an overall HIV prevention set of behaviors. So maybe more people decided to opt for condoms, but overall maybe we see more prevention benefits. That's a complicated analysis, but that's something that we want to explore.
Great, thanks, Sinead. Actually, related to that, there was a question on whether PEP was made available, and was this also taken up by the girls? Because among female sex workers in Nairobi, PEP seems to be more popular than PrEP, despite the higher pill burden and side effects. So the question is it attractive for adolescents too to have PEP instead of PrEP?
Yeah, so that's a great question. And in our study, there were very few requests for PEP. I think because a lot of people understood and kind of accepted, at least in principle, how PrEP was going to work and assumed that it was protecting them against HIV infection. And we showed some data about the proportion of people who believed that sort of at study start. There were a couple of instances where young women experienced sexual assault, and to err on the side of safety, and because they kind of had some intermittent PrEP use, we offered PEP. But on the whole, kind of I think sort of the data that we present suggests that, kind of there is a fair amount of PrEP use and consistent PrEP use that is being undertaken within this population. And my own experience working in South Africa, sort of by comparison with sex worker populations, we've seen less than 10% uptake of PrEP in that population. And so I think, kind of these are different populations who, kind of are making different prevention choices on the basis of their lifestyles and their ability to use condoms and so forth. And these are sort of some of the things that we need to learn and understand more about. But it's clear that one size doesn't fit all in these settings.
Mm-hmm. And actually, related to that, there's a question on whether whether you think that it would help or hinder PrEP continuity if young women knew each other before starting. So if a group of young women came together either through just being friends or through sports to hear about PrEP, or is it an issue of confidentiality and they risk losing their self-esteem, and peer pressure can be a problem as well. So whether you think friendships are good, are beneficial for this.
Yeah, I think that that's an interesting question, because sort of how we saw enrollment play out was really groups of young women coming together to the clinic to hear more about PrEP. It's clear that friendship groups are influential, not in this study, but in another study I'm aware of, we heard about how if there was a sort of peer influencer who enrolled in the study, a lot of young women might also enroll because of that sort of need to be part of the group, when in fact they may have felt less confident about their own sort of need to use PrEP. So that's where kind of friendship can potentially undermine sort of PrEP programs, because some people may be joining for the novelty or because their friends are doing it. By the same token, it's clear that it's been very important within these settings, particularly with these vanguard projects and sort of new users of PrEP, that there is a population of young women, a network of young women who sort of can all identify and provide support to each other. And that's what we heard from the clubs, is that it was very important for those young people who attended the clubs to know that there were other young women like them, and they definitely assisted each other in solving, kind of when to take your PrEP, how to disclose potentially to family members, how to deal with sort of remembering to take your pills. So I think it's pros and cons. And so in this study, there were definitely people who joined clubs together and were friends, and definitely those clubs, there were some strong bonds that were created and persisted well beyond sort of the required sort of 4 sessions.
Great. Thank you. There's a question on behavior change during the 6 months, and whether you looked at it, and whether it's possible that during the empowerment clubs and being on PrEP that participants change to safer behaviors, or rather safer behaviors related to HIV, which may make PrEP less important to them. And so I guess this is another question about whether this is the reason for the decline of continuity.
Yeah. And this is a great question, and I think this really gets to the heart of what we're all grappling with in PrEP programs, is that if we see declines in continuation, unlike in ART, in treatment programs, it's not necessarily a train smash if you're seeing increases in other preventive behaviors. It's quite difficult to get at that, so we have some data, and we are trying to sort of look at this sort of overall prevention effectiveness, and kind of hopefully we'll have some results to report on that. I mean, I really think sort of one of the things to say is that we did see some HIV infections in young women who participated in this study, but they were all in young women who had stopped taking PrEP. So I think while at least young women are taking PrEP, there does appear to be a prevention benefit, although we weren't powered to address that particular question, but just anecdotally, there is a sense that there is protection. But obviously there might be other factors at play in those that decide not to continue PrEP, and we need to investigate that further.
Mm-hmm. And so related to that, would you say that based on these results, would you still recommend attendance of empowerment clubs for this kind of a PrEP adherence program?
So I think we, kind of this is our first very crude attempt to think about adherence support strategies for young women. And I think sort of in this most sort of crude approach, there doesn't appear to be an additional benefit. And I think we should sort of take the data and try to understand a little bit more. And certainly, kind of when we're thinking about how to scale programs, clubs definitely may not be useful in settings like ours in Johannesburg or in Mwanza, where, kind of the operational requirements of getting healthy young people into a club every month are quite challenging. But one of the next steps that we're looking at as well, if people can't participate in person, could they participate virtually? So could we perhaps offer people participation in a WhatsApp club where potentially some of the same content could be offered, but people don't have to be in the same room to receive it, or at least not at the same time. So that's part of the answer. And I think the other part is that it probably needs to be, it may be situation dependent. I've heard sort of from other parts of the country different stories, even within the same city, of where clubs have just been impossible to deliver to young women versus where they're kind of in very close-knit communities where they're highly desirable and you get high participation. So there does seem to be something about what the underlying social structure is and the social networks and how close-knit those communities are. And, kind of there may be value in evaluating this type of approach in that type of setting to see whether there is additional benefit.
Great. And I guess it sort of touches upon two other questions around your plans for conducting similar studies in a different cohort to reassess the intervention, or what would the next PrEP adherence intervention look like based on this experience? You touched upon it already, but I don't know whether you have more to add on that.
Yeah, so I think the thing that we're interested in, so two things. One is that it's clear that there is a population of people who enjoyed the experience of clubs and derived some benefit, even if that didn't translate to PrEP continuation. And so we want to understand a little bit better what some of those other benefits might be, and particularly because we found a kind of high requirement for mental health services in this population, and sort of clubs and empathetic listening there is some evidence to suggest that it's beneficial as an intervention for young people. So I think that's one avenue of inquiry. Mm-hmm. I think in terms of what this means for PrEP programs, we want to start looking at sort of differentiated models of care for PrEP. I think up until now, most programs have sort of offered everyone everything, and it's clear that there are some people who may not need much intervention and some people who may need a lot of support. And so kind of we're doing some work really to sort of look at whether you can sort of provide an escalating set of interventions to support adherence based on whether or not kind of young women who want to continue PrEP are able to adhere and are just struggling. And so I think sort of looking at differentiated models of care is going to be sort of the next question we want to pursue.
Great. Thank you, Sinead. And actually, I had a question on the qualitative work and how you'd reconcile those results with this overall trial result.
Yeah, so I think, kind of it's very clear that young women who participated felt that they benefited. Kind of in one of my reflections, and one of the things that, in fact, the study staff would say is once people join the first club, they don't want to leave. So kind of the goal was to get people into the first club. But for many people, they're very busy. They have demands on their time. In South Africa, this was a population of students. Johannesburg is a city where people are upwardly mobile. And so you're competing with a lot of other sort of information and opportunity to kind of get people in. But because there does seem to be some value attached both from the healthcare provider perspective, from the qualitative data, as well as the end user perspective, I do think we want to try to understand whether these clubs perhaps had benefits on some intermediate outcomes. I mentioned the mental health outcomes, because in some instances they may be repurposed for other uses. It's just that sort of, kind of perhaps we were ambitious to think that these clubs could kind of translate into direct benefits for such a complex behavior as PrEP continuation.
Mm-hmm. Yeah, interesting. And did you does your data, how does your data compare to other PrEP projects in adolescents, either in the region or outside the Southern African region?
So, I think if you're used to seeing antiretroviral treatment programs, and I saw a comment kind of in the questions about sort of the retention being low, but I'd actually say that for adolescents and for a PrEP program, when I now look at this data in sort of growing entirety of data that's available for this age group, our continuation rates are actually quite good, and our uptake was very good. And especially if you look, for example, at some of the data that's coming out from some of the sort of large-scale demonstration programs, kind of linked, for example, to DREAMS, kind of their uptake has been a lot lower, and continuation sort of out at 3 months is already at 25%. So, kind of you could argue this was a smaller project, maybe more attention was paid, but I do think that, kind of it demonstrates that with young people, you are able to achieve good rates of continuation. I also know, just reviewing contraceptive continuation rates out to 12 months amongst this age group, our data looks very comparable to that. So if you look at the ATN studies, if you look at plus pills, if you look at our data, if you look at some of the other data that's coming out from the demo project, I think that this is a reasonable result and shows that when you provide youth-friendly services and kind of non-judgmental services, sort of, and a range of bundled services for young people, they do kind of appreciate and seek out these prevention services. I just think there's a lot more work to be done to really understand prevention effectiveness. So, kind of does that PrEP continuation align with ongoing risk behavior? And how much do we know about sort of how risk behavior oscillates and fluctuates in young women's lives? And I think there's more work to do there.
Absolutely. And would you say that this work has influenced PrEP programming in the region?
Yes, I think one of the goals really of the EPSA program and sort of what we've been encouraged to do also through UK Aid is really to make sure that our work is informing national programs. And we were fortunate that this project was funded at a time where in both countries decisions were being made about how to roll out PrEP, and there was a real request for sort of data to inform that programming. And so in both countries, the study team members participated in the PrEP technical working groups, and much of sort of what we were learning as we were doing was really informative for the national program and helped, I think, shape sort of the model of delivery. And we already know that within our national program in South Africa, for example, clubs are not recommended. And now we have evidence which says, at least in our setting, kind of that's maybe a reasonable decision. So I think, kind of these projects are very helpful or have been helpful for advancing PrEP access both in South Africa, and we're hearing now definitely in Tanzania, and in fact have heard that, kind of in Tanzania there's a desire to now offer PrEP to women in Tanzania who participated in POWER sort of for a much longer period. So that's really encouraging for us.
Yeah, that's great. And I guess another question that sort of has come up related to understanding the true value of these empowerment clubs. What do you think should be done to increase participation?
Well, I think what we can't, there does not appear to be any kind of characteristic that predicts who doesn't attend a club. So it's not a particular age group, it's not a particular set of behaviors, it's not whether or not you've experienced violence. We couldn't find anything at all in any of the baseline characteristics which separated out those that did and didn't attend empowerment clubs. So then we look at the qualitative data and we look at sort of what people were telling us and about why they didn't come to clubs, and they said they forgot, or they were too busy, or it's far to go to the clinic. And so those are operational issues and logistical issues, and we're hearing some of those same messages at least in South Africa, from other parts of the country. And so sort of some of the ways then to kind of address that are either to make the clubs virtual as opposed to in person, and the second way potentially is to provide incentives to attend clubs. And in fact, there was another EPSA-funded program that was looking at cash plus clubs, and definitely the cash is a hook in. It also perhaps facilitates kind of regular attendance by sort of providing taxi money or some other transport money.
Great. Yeah, that's really interesting. And was there have they shown results of whether the provision of incentives increased participation in the clubs, or is it still ongoing?
No, that work has been published. It was the Girl Power study, where they were looking at four models of service delivery for young people, with the kind of standard of care being sort of the base case. And then they looked at youth-friendly services with empowerment clubs, and youth-friendly services with empowerment clubs plus cash. And they got highest attendance at services with that model. So the cash definitely facilitates engagement. And based on our data, I mentioned that staff said, well, once people attend the club, they don't want to leave. But perhaps what we need are some hooks to draw people into those initial interactions, and that's where cash may be useful. And I think there is other evidence from the violence field. I think the image trial, there was talk about how the loans were the initial driver of joining loan clubs, but it was that then sort of created the environment in which to deliver empowerment material, which was well received. So clearly, there are things we should think about. And I think for us, the tension was really, we wanted to deliver an intervention that was going to be scalable within our health system. We didn't want to add on too many things, and we had already had a lot of pushback about cash transfers within our setting, at least in South Africa, which may have made us a little bit more cautious. But, it's certainly sort of worth looking at that combination in other settings, perhaps.
Mm-hmm. Great. Thank you very much, Sinead, for a very interesting discussion and an excellent presentation. We've actually reached the end of the hour, and we've gone through most of the questions. For the audience, we just want to let you know that all of our previous Learning Lab presentations are available on the Stripe website, along with materials addressing issues and structural drivers. So thank you all for your participation, and thank you once again, Sinead, for this great presentation.
And thank you to everyone for their questions, and to you, Meghna.
Thank you. Bye-bye.